Yeah, so my name is Max Takei. I'm an academic clinical fellow with the University of Oxford, and I share my time between doing research and seeing patients with mental illness.
Okay, so you're a medical doctor, but I did some quick Googling, and you have a PhD in is it biomedical engineering?
That's right. Yeah, I've done my PhD in engineering, developing techniques for brain imaging.
Okay, cool. So you're not actually a psychiatrist yourself, but you're working in the Department of Psychiatry?
Now, I'm not training to become a psychiatrist.
You are in training? Okay.
Yep.
Awesome.
So I've done my medical degree after my PhD in engineering.
Yeah, right. Hopefully you got a scholarship so you don't have to pay lots of tuition fees, because that would be very expensive.
Yeah.
Thanks so much for your time. I'm really interested in long COVID, and it's such an intriguing area that I think that we're only still scratching the surface of. I'm wondering though, are there aspects of long COVID that sort of surprise you?
Well, I think, I guess from our study, we sort of knew before we did the study that long COVID was a thing, that people were experiencing symptoms that were various and affecting different systems of the body for a while after COVID. But what we were unsure is whether that would manifest in people seeking medical help for those symptoms. So what I mean by that is, a lot of the studies before our study were based on self-report surveys of those symptoms. Now, if you survey your colleagues about who has a headache today, you'll probably see that quite a lot of them have a headache. They might not have had coffee, they might have had a poor night sleep, etc. But they don't seek medical attention for that, because that's sort of part of our sort of, I guess, Western life or way of life, and we sort of get used to it. And there is a big difference and big leap between that and seeking medical attention for those symptoms, to the extent that those are recorded then in the electronic health records. So in a way, we were surprised by the extent to which people after a diagnosis of COVID were experiencing those symptoms, to the extent that they would seek medical attention for them.
Because one of the things that you observed was that about almost 40% of patients with long COVID symptoms recorded at 3 to 6 months didn't have these same problems, or at least weren't diagnosed in the first 3 months. I'm wondering if perhaps some of them might have had those problems throughout their first 6 months, but just didn't get them looked at because they hoped that they would go away. And when they hadn't gone away, they did seek medical attention, or whether these are truly new incidences of problems that occur, 3 to 6 months after the infectious period.
It's an excellent point. I think we cannot say with electronic health record data which of those two is the correct answer. And you're completely right. That they might not have sought medical attention for them in the first 6 months. In the first 3 months, I would add to that there's also a possibility that in the first 3 months, they might have sought medical attention for those symptoms, but the medical practitioner would have said, "Well, that's COVID. You're just having COVID." Whereas, when they seek medical attention in 3 to 6 months, that then gets encouraged in different ways, because at least at the time when we did the study, at the time where the data was collected, long COVID was not really a thing yet, which means that clinicians would not have thought that this might be related to COVID. They were just encoding it as, well, we don't know, you've got a headache. Let me type in your medical record that you've got a headache, but I can't quite pinpoint what the cause of that headache might be.
Yeah, and so where there is like a diagnosis, this wouldn't be just one episode of headache. You would be getting a diagnosis for persistent headaches. This would be something unusual, wouldn't it?
Well, it's difficult to know exactly the behavior of individual clinicians. In my own practice, I would think that we wouldn't encode a headache if somebody just says, "Oh, and by the way, I've got a bit of a headache today, but might just be lack of coffee." I don't think anybody would sort of code that. But what exactly is getting coded is difficult to say. So that's one limitation of that type of data, which is that we don't know exactly, whether those are persistent symptoms, whether they are severe symptoms, or whether they're just symptoms that for whatever reason the clinician thought were worth mentioning in the patient's medical records.
I was wondering if you can talk a little bit about the differences that you observe between influenza and COVID in terms of the persistent symptoms.
Yes, that's one big part of the study, which is that we compared the cohort of patients with COVID to the cohort of patients with influenza. And what we found by and large is that the type of symptoms that patients experience after the flu, so after an influenza infection, in the 3 to 6 months are quite similar to the symptoms that patients experience after COVID. So it's not that there are specific symptoms that only occur after COVID and never occur after influenza, but they do occur a lot more after COVID than after influenza, about 50% times more, so 1.5 times more, to put it that way. That in a way is a surprising number in two ways. It's surprising because it sort of validates the fact that there's such a thing as long COVID, and that these patients are experiencing symptoms in the 3 to 6 months after COVID much more than after another infection, but it's not 10 or 100 times more. And so it might be, that certainly is a possibility from our study, that it's sort of a long flu concept, if you will, has been overlooked, and that patients after the flu might not recover as quickly as we might think, and that they might, in the 3 to 6 months after the illness, still experience symptoms, but it's to a lesser extent than after COVID, according to our data.
Yeah, my sort of feeling with flu is that often it may be undiagnosed anyway. People may have a viral upper respiratory infection that just gets put down as a viral illness with unknown etiology.
You're completely right. And I think that's an important point, which is that the data that we have where we use diagnostic codes for influenza and for COVID are probably enriched for more severely affected patients. What I mean by that is that compared to the whole population who's got the flu at some point during the 2020 season, we probably captured those that were severely affected enough that they made it to the electronic health record. That also probably applies to COVID. Quite a lot of people would have had COVID without noticing it, or they would have had a test at a testing center and not necessarily see explanation as a result of that. And so as a result of that, it might be, and it depends from practice to practice, but it might be that this does not get carried through to the electronic health records. And the reason, one hint that we have at the fact that this might be the case, is that the hospitalization rate, so the number of people who get hospitalized at the time of the COVID-19 illness in our data is about 20%. And that's a lot more than the general population. So it seems that both the flu group and the COVID group in our data were both more severely affected than the general population would have been with those infections.
Okay. So I see that the study talks about the risk for long COVID being higher among those who are hospitalized for COVID-19. And so that's looking at risk on an individual basis. But then if you look at the sort of population risk, if you can talk about it like that, clearly the hospitalized segment is quite small compared to the overall group of people affected by COVID. So when we think about long COVID sufferers, are they more likely to be people who had a mild to moderate SARS-CoV-2 infection?
So that's a good point. If I understand your question correctly, is in a way in our data, those who were more severely affected were more likely to suffer any long COVID symptom. But by and large, people are not severely affected. And so the bulk of patients with long COVID would be people with relatively milder infection. You're completely right. And so yes, so overall, and actually the difference between the most severely affected patients and not so severely affected patients was, again, not a tenfold ratio. It's a 50% increased risk or 40% increased risk, depending on how you define severity. Actually, if you define severity based on being hospitalized, which is quite severe enough at the time of your COVID-19 illness, that's only that brings the risk of long COVID symptoms only by a factor of 1.2, increases by a factor of 1.2. So not at all a tenfold increase. So the risk of long COVID symptoms is quite high in people, even if they did not have to go to the hospital for COVID.
Were you able to see any long COVID phenotypes, like different patterns of manifestation, particularly, from those that were hospitalized versus non-hospitalized?
Yes, we certainly did. So we found that those who were hospitalized, for instance, were more likely to suffer with cognitive problems, so what we call brain fog, but less likely to suffer headaches, for instance. So what that really means, and that's quite striking if you think of it, what that means is if you had a milder version of COVID, you're more likely to have headaches in the 3 to 6 months after COVID, and that's quite striking. And similar differences were, well, not similar, but differences were also seen between, say, men and women. So the difference in absolute risk of having a long COVID symptom was similar between the two. Women were slightly more at risk, but not substantially so. But they were much more likely to suffer headaches, more likely to suffer myalgia, so muscle aches, but less likely to suffer abnormal breathing, so breathing problems and cognitive problems than men were. And so we found those sort of different profiles of symptoms between different subgroups of the population.
I guess the question is, what is the mechanism driving these particular differences? And your research that was presented in this study didn't really look at that, but do you have any thoughts on what might be the underlying biological mechanism?
So you're right that we can't really tell the mechanism using the sort of data that we have. We need sort of better data, prospective studies where you can actually follow individual patients and then ask them specific questions. But I mean, I guess there's two mechanisms. There's one that might be very interesting. There's one that's completely mundane in a way. The mundane mechanism, to start with that one, is that the baseline rate of those symptoms in those different subgroups is different. So if we talk about men and women, it might well be that men have more cognitive problems than women, and women have more headaches than men. And so that gets reflected in the data, because obviously the data captures not only symptoms of long COVID that occur as a direct result of COVID, but also as a result of the baseline rate. So that's the sort of not interesting explanation, if you will, but very, very, very possible. Not really explaining the difference between hospitalized and non-hospitalized patients, because those were very similar at baseline. But there are some other possibilities. There are possibilities that one possibility, if I talk about hospitalization, for instance, is that the cognitive problems that occur as a result of long COVID, as a result of COVID, might be due to small hypoxic injury to the brain. So the brain is not receiving enough oxygen during a particular time, and that sort of causes those cognitive problems down the line. And we've got evidence from other studies that that's the case. So there's been a study by Adam Hampshire in the UK, where his group has been following the cognitive symptoms of patients after COVID, and what they found is that if you were more severely affected in terms of your respiratory system, so you were more short of breath at the time of your COVID-19 illness during the acute phase, you're more likely to have cognitive problems down the line. And so there might be that this is the mechanism driving some of those symptoms, and other mechanisms might be then driving other symptoms, which are then more reflected in milder cases of COVID.
What about with the headaches? Do you think there could be some vascular component?
There might be, but then again, you would expect in that case that would be more common in more severely affected patients, and it's the opposite that we see. One possibility that we need to keep in mind, that's something that actually has been sort of under the spotlight more recently, which is don't put everything down to long COVID. And that's important. So if a patient comes to the hospital with a headache, say, and they've had COVID 2 months ago or 3 months ago, it's important to investigate that headache fully and not to put it down to long COVID. And one possibility is that if you've had very severe COVID, then you're more likely to receive the right, so to speak, diagnosis for your headache. It might be that you've had a bleed in your brain, for instance, to take a very severe example. Whereas that gets misdiagnosed if you've had sort of a less severe form of COVID. That's one possibility. I don't know how valid it is, but it might be that sort of dynamics at play as well, and we need to be paying attention to those.
I see that you have an interest in the UK Biobank data, and of course we saw that really interesting preprint that came out from your colleagues. Do you have any thoughts on that paper and how that may relate to the research that you've done?
Yes, I suspect you're referring to the paper where they've looked at pre versus post COVID brain imaging study. Well, that's an absolutely fantastic and fascinating study that I wasn't involved in, where for the first time they were able, because of the capability of the UK Biobank, to look at the brain of patients after they've recovered from or after they've had COVID compared to before. So it's not just looking at a group that didn't have COVID and a group that did have COVID. They were very much able to follow the same patient before and after COVID. And what they found is that there were some differences in the brain after COVID, and that's alarming, but in a way that might also be explaining some of the symptoms that we see, not least the cognitive problems, but also quite a lot of the neuropsychiatric presentations, such as mood changes and anxiety, for instance. That was one of the most prevalent symptoms that we've seen in our data.
Yeah, so in your study, you didn't have, you weren't looking at COVID sufferers versus people during the same period who didn't have COVID as controls. So
we used controls. As controls, we used people with the flu, so influenza.
Exactly.
And they had the flu during the pandemic. So that was an important aspect, because for some symptoms, and obviously the one that comes to mind first is anxiety and depression. This is very much influenced by the pandemic as well. So it was important that, regardless of the fact that patients had or did not have COVID, so it was important for us to have a group of controls who had another health event, in this case influenza, during the pandemic, because they were in a way sort of going through the pandemic as their sort of COVID peers, if I can put it that way. And so they were, suffering the same sort of impact of lockdown, economic austerity, uncertainty, etc., on their mental health.
Yeah. So where do you go from here? What's your next lot of research going to look at?
So I think what we desperately need now are two things. We need to understand mechanisms, and we need to understand treatment, the best treatment for that. So in order to understand the mechanism, we need to move away from the sort of study that I've been doing. I mean, they will still play a role in understanding other things, but and they can inform the sort of other studies that we need to do. But as I was saying, we need to do what we call prospective studies, where we can actually clearly define what sort of questions, what sort of tests do we want to run on different patients. And there is a study in the UK called FOSP-COVID, which is trying to do exactly that. And that's following patients, not just their electronic health records, but also doing some brain imaging on them, doing some blood tests, but also doing some actual cognitive testing, exercise testing, etc., just to have a much deeper understanding of what's going on in those people's bodies, to understand the mechanisms. And that will hopefully inform how to best treat those symptoms. What are the best drugs or non-pharmacological treatments for those patients? I think those are the two priorities that I will be focusing on.
Yeah. What about you yourself? What are you doing?
So I'm hoping to be involved in that first COVID study and using some of that data. I will continue to use the sort of data that we've been using from the Trinetics network to inform the sort of studies that we do. So it's sort of there can be some synergies between the sort of data that we're using, and that's going to be my focus for the next 6 months.
Right. Excellent. And do you think you'll be needing to work closer with neurologists, immunologists, infectious diseases experts? Like, do you sort of see this as being much more multidisciplinarian in terms of the approach to untangling this?
Yeah, absolutely. I think that's crucial. So we are psychiatrists, so we got into that sort of studies because we were initially interested in the psychiatric consequences of COVID, and that was the first paper that we've published on that. Then a neurologist joined the team, so Masood Hussain, who's a neurologist and is a co-author on the paper. And so we brought the sort of neurology to it. And then we sort of thought, well, actually, we can just apply the same strategies, the same sort of research approach to investigate long COVID. That's how we got into long COVID. But you're completely right that long COVID is such a multidisciplinary thing. It affects so many systems of the body that you need to have a deep understanding of the different systems. So we do liaise, even though they're not necessarily co-authors on the paper, but we do liaise with a lot of infectious disease specialists, public health specialists, and to understand to better understand what it is that we are looking at and measuring.
Max, is there anything that we haven't discussed that you wanted to mention before I let you enjoy the rest of your morning?
I think we've covered quite a lot. So I'm pleased that we've had a chance to discuss the limitations of the study, which is always very important because it's a large study, and so it's got many advantages to it, but it's also important to understand the limitations of the data and the need for additional research as well. So,
yeah, because I saw you kind of referenced the Veterans Affairs studies that have come out from St. Louis, and I think that those studies have been really interesting as well. But obviously, that's men are overrepresented in that database. But it's such an intriguing area. Are there sort of what are your big questions, if you like? Are they just to do with mechanism?
I think so. I guess we can try and blindly to apply treatment, and it's not necessarily. I'm not saying that in a derogative way at all. It's for instance, we know that there are some clotting problems, coagulation problem in COVID. So it's not unreasonable to try an anticoagulant as a way of treating it. We know there's a massive inflammatory component to COVID. So it's not unreasonable to try an anti-inflammatory drug to prevent or treat long COVID symptoms. So it is fine, and there are some people doing that. But I think having a deep understanding of the mechanism involved, that's what's going to aid sort of drive science forwards, because we might then find that some of those mechanisms are shared in different infections. We were talking about sort of potential long flu concept. Well, it might be that some of the mechanisms are shared with the flu, and they might explain why people after the flu sometimes also experience long symptoms. But it would certainly also help us understand and pinpoint and define new treatments specifically dedicated for those symptoms. And I think for patients, understanding what's going on is therapeutic in and of itself. I mean, I don't want to undermine obviously the role of actual therapeutics, but I think what we're seeing in patients with long COVID and the patients with long COVID that I'm seeing is that there's this big question mark about what the hell is going on? Why am I feeling the way I am? And I've just had COVID, and it was not even that bad. And I think, it sort of empowering those patients by saying, look, this is what we think is going on. Now do you want to join force and do research to even better understand it and start treating it? And I think that's very important and critical.
Awesome. I'll let you go. Thank you so much for your time. It was great to meet you.
Thank you very much for your time. Great to meet you too.